Okay.
All right, welcome everybody to this session. I'll give it a second because I know Zoom takes a moment to let people into our room. All right, well, let's go ahead and get rolling, even though some people are coming in. Welcome to Machine Learning in Healthcare. I will be your chair for the afternoon, well, depending where you are, whatever time it is. And usually the chair supplies a laptop. This year I don't even get to do that, but I will be keeping time. And we're gonna go ahead with a format. We're going to have 3 fantastic presentations. We're going to give each of those presentations 20 minutes, then 10 minutes for discussion, and then we'll have 5 minutes directly after each presentation for Q&A. If we then have any leftover time at the end, we'll have a broader discussion. One just quick logistical note, the way to ask questions is in the Q&A function. I will do my best to condense and curate questions to give them to the speakers. And I'm going to be ruthless on time since Zoom just kicks us out at the end. We can't really stay in the room, so we got to be on time. So without further ado, let me turn it over to Jason Abelek presenting the first paper.
Right, excellent. Thank you, John. I just want to state for the record that I never agreed that this presentation would be fantastic. This is joint with Leila Aga and Dave Chen, who I think most of you know, also Diana Zhu, who is an excellent grad student at Yale, and Danny Singer, who is one of the leading physicians studying atrial fibrillation and came up with one of the guidelines that we'll be talking about today. Our starting point for this paper is that in many settings, doctors don't allocate treatments to the patients who would appear to benefit most. There's now a substantial literature demonstrating this. If you think about the things that health economists more traditionally study, so things like how are physicians reimbursed, or what kind of cost sharing do patients have? A lot of these are things that you might think might lead to overtreatment on the margin. One of the points that we tried to make in my original paper with Leila, and that I think is borne out in several of these other papers, is that the welfare costs of misallocation are potentially first order relative to these things that economists typically study, and maybe even substantially larger. So where we're going in this paper is to investigate 2 broad strategies to try to fix these misallocations. One is to make doctors more aware of guidelines, and a second is to promote stricter adherence to guidelines. One can do this both for existing guidelines, so we'll study a specific existing guideline, and for alternative guidelines. So the clinical setting that we will be thinking about is the use of anticoagulants to treat patients with atrial fibrillation. So atrial fibrillation means you have an abnormal heart rhythm. It affects about 5 million people in the United States. If you have atrial fibrillation and it is untreated, you have about a 5% risk of having a stroke each year. The typical treatment is anticoagulation, so blood thinners. These will reduce your risk of having a stroke, but they increase the risk of certain kinds of hemorrhages. Typically, when doctors decide which patients to treat with anticoagulants, they look at a risk score called the CHAD score that is designed to predict your probability of having a stroke. So the CHAD score is among the most well-known and widely used risk scores in medicine. As I mentioned, when you're deciding whether to prescribe anticoagulants, you're weighing strokes against bleeds. There's actually relatively little formal guidance for doctors to use to assess bleed risk. There's something called the HAS-BLED score that was developed fairly recently after most of our sample period, and in any case is not really validated for atrial fibrillation and seems to be rarely used. Okay, so what are we going through in this paper? We're going to combine data on guideline awareness, treatment decisions, and treatment effects. So the first thing we're going to do is we're going to analyze how treatment decisions change following guideline awareness, where guideline awareness is going to be defined as the point in time when a doctor starts mentioning in their notes that they use the guideline in their decision making. Next, we'll ask, okay, if treatment decisions change, does this make patients better or worse off? In order to do that, we will create causal forest estimates of heterogeneous treatment effects by pooling the microdata from 8 RCTs that have been conducted to investigate how anticoagulants impact strokes and bleeds. This is going to incorporate many factors not in existing guidelines. Then we're going to analyze how physicians respond to treatment effect variation before and after guidelines. Finally, we'll say, in light of how they respond to the variation in treatment effects, in other words, they become more sensitive to treatment effects covered by the guideline once we give them that information? Do they change their sensitivity to information not included in the guideline? We'll then ask, in light of this, we'll simulate counterfactuals where we change the content and implementation of guidelines. We'll find that greater awareness helps. So if more doctors were aware of the guidelines, we would see modest improvements in outcomes. Adherence to existing guidelines helps much more, would prevent about 13% more strokes. Adherence to optimal rules is much better still and would prevent 47% more strokes. So there are two major conceptual challenges to our approaches here. The first is the question of the external validity of the trial estimates. So we're estimating treatment effects in this trial data, and then we're using those treatment effects in observational data where treatment is not randomly assigned to ask, what would outcomes be under different counterfactuals? So how do we know that the trial estimates are externally valid? We do two things to try to assess this. First, we ask whether the estimating our causal forest on a subset of trials but leaving others out correctly predict variation in treatment effects in left out trials. We find that they do. Second, we find that our causal forest estimates in the trial data predict variation in heterogeneous treatment effects estimated by OLS in the observational data. So taken together, these two facts suggest that our treatment effect estimates are not just noise. They vary in the ways that we would expect, or outcomes vary in the way we would expect if these are really capturing variation in treatment effects. Now, I should note here that before we wrote this paper, we spent about 5 years trying to write a different paper where we used quasi-experimental variation to try to estimate heterogeneous treatment effects in the observational data. We became increasingly convinced, so we were using like a Judge's instrument type design, that the assumptions necessary to estimate heterogeneous treatment effects with these designs are extremely strong, and that the right way forward here is to use machine learning on trial data and then to combine that, to supplement it with estimates and observational data, including potentially quasi-experimental estimates, although today we'll compare them with the OLS estimates. All right, so the second major challenge we have is the challenge of private information. So what we will show you today, so the question is, if we're saying doctors would have better outcomes if they adhered to some strict rule, is it possible that doctors are departing from that rule because they know better than we do? So there's 3 ways that we can try to investigate this, one of which I'll tell you about today, one of which is in the paper, and one of which we're working on now. The one I'll tell you about today is that we ask, are doctors responsive to the residual variation in stroke treatment effects not predicted by the guideline? What we will find is that doctors are sensitive in their treatment choices to the variation in treatment effects predicted by the guideline, but they don't respond at all to any of the variation in treatment effects not in the guideline. So that goes against the idea that, oh, when doctors depart from the guideline, they're using other information about treatment effects. We also show in the paper that the factors that might predict stroke or bleed severity that are separate or conditional on having a stroke or bleed explain very little variation in treatment choices. The last exercise we're working on is we can bound the degree of private information given the relationship between OLS and the trial data, assuming external validity. But taken together, all of this suggests that, look, doctors do frequently depart from treatment effects when they make their treatment decisions, but when they're doing so, it doesn't seem to be because they know anything better about treatment effects or what outcomes will be. It seems to be because they just have certain stylistic things that they like to do for certain types of patients. Okay, so to tell you a little bit more about the clinical context and our evidence on CHADS2 adoption. So the CHADS2 score is this risk score that incorporates congestive heart failure, hypertension, age, diabetes, and stroke. It gives them 1 or 2 points. You add them up, you get the CHAD score. In light of the CHAD score, then you get a recommendation of whether you should administer anticoagulants. So it's a very simple rule. So we're going to analyze the impact of the CHAD score in the Veterans Health Administration data. This is data that our co-author Dave Chen has used to great effect in a variety of prior papers. It's basically chart data for people enrolled in the Veterans Health Administration. We're going to restrict to patients who have been diagnosed with atrial fibrillation. We'll link them to the physician who was seen right after diagnosis. We'll have, in total, a little over 100,000 patients. We'll measure guideline awareness by the first mention of the CHADS-2 score in their clinical notes. Treatment is whether the patient was prescribed an anticoagulant. And then we observe many, many comorbidities and covariates for every patient, including the CHAD score and many variables not in the CHAD score. So the first thing I want to show you is what happens when physicians adopt the guideline, and it seems like they change their behavior. So this is an event study graph. Time 0 is the year when they first note the guideline. Prior to adopting the guideline, they're actually more likely to prescribe warfarin to patients with a low CHAD score, who the guideline says will benefit less than patients with a high CHAD score. That changes dramatically after they adopt the guideline. We see the treatment rates for low CHAD score patients decline by about 5 percentage points. For high CHAD score patients, treatment rates increase by 2 percentage points. This raises the question, what does this mean for patients? So to do that, we go to this microdata from several randomized trials. It's about 7,000 patients across 8 randomized trials. We observe a number of patient characteristics in every trial. We confirm balance. In these trials, we're going to estimate causal forest to basically ask, how do stroke and bleed treatment effects vary with all of the observable attributes of patients in these trials? We estimate these causal forests. We find that roughly the clinical variables that we would expect to matter seem to matter a lot. Everything seems to matter with roughly the correct sign. So for example, the biggest predictor of benefits in terms of reduced stroke in the stroke causal forest is actually stroke risk, then age, systolic blood pressure, etc. Okay, so external validity. First thing we do is try to validate that if we estimate the causal forest in some subset of trials, we can correctly predict the variation in treatment effects in the left out trials. So we run a regression to validate that this is the case. And the short answer is basically that it is, that the stroke and bleed causal forests predict treatment effects in the left out trials. Not only that, if we break down the treatment effects into the component of treatment effects predicted by the existing guideline and the residual component, we find that both of these predict treatment effects in the left out trials. So this suggests, yes, it provides further validation for the CHAD score, but it also suggests there's lots of variables not in the CHAD score that successfully predict treatment effects out of sample. Now you might say, okay, well, trials are different from observational data. Maybe there's different ways in which the patient population differs. So a further exercise we do, this is a bin scatter. On the x-axis, we have OLS treatment effects in the observational data. On the y-axis, we have our causal forest estimates of treatment effects. And you can see that these scale pretty much 1-to-1. So this is roughly what we expect. We don't expect it to line up perfectly because there's various biases in the OLS, in the observational data, but this is roughly what we expect if the variation that we document in these heterogeneous treatment effects in the trial data is real variation. It's the impact of treatment, and it's not just some noise due to estimating with a small sample or something like that. All right, so as I mentioned, there's substantial residual variation in treatment effects. We find that treatment effects are substantially larger. In other words, you reduce your stroke probability of having a stroke by more at higher CHAD scores as we'd expect. But you can also see there's lots of variation conditional on the existing guideline, conditional on the CHAD score. So the next thing that we are going to do is we're going to ask, how do physicians respond to treatment effects in their decision-making before and after the CHAD score is introduced? So let's focus first just on column 1 here. So in column 1, row 1, we're saying, hey, prior to the CHAD score, physicians in their treatment decisions are sensitive to CHAD's treatment effects. In other words, they're more likely to treat the patients with larger treatment effects. This is because they know things like, hey, if a patient has a stroke history, they're more likely to benefit from being anticoagulated than if they don't. We find after the introduction of the CHADS score, physicians become almost twice as sensitive to these CHADS treatment effects in deciding which patients to treat. Moving to the second panel, we look at the residual variation in treatment effects. We can see that prior to the CHADS score, if anything, there's a wrong sign responsiveness to the residual variation. We don't make too much of that because depending on what controls we include, basically, the main thing is it's about 1/10 as large as the responsiveness to the CHADS component of treatment effects. In other words, we have all this variation in residual treatment effects that doctors don't appear to be responding to very much when they decide what patients to treat. After the CHADS score, there's relatively little change. Maybe they become slightly more sensitive, but still they're not responding very much to this residual component of treatment effects. Prior to the CHADS score, they are responding to bleed treatment effects. They're less likely to treat patients where you're likely to induce a bleed. And after the CHADS score, they become maybe a little bit less responsive to these bleed treatment effects. Okay, so the main takeaway is they're responding to the treatment effects predicted by the CHADS score. They're trying to not treat patients where warfarin or anticoagulants are likely to induce a bleed. They don't seem to be responding much to this residual variation in stroke treatment effects. All right, so let me move on to our counterfactuals. So first counterfactual, how do observed treatment choices compare to randomly assigned treatments? And the answer is they're only slightly better than randomly assigned treatments. This is, all of these patients have atrial fibrillation. So it's not like we're randomly treating people in the world, but the short answer is whatever information doctors use conditional on knowing that the patients have atrial fibrillation, they don't do much better than random chance in preventing strokes and not inducing many bleeds. So it turns out that guideline awareness does prevent strokes. So universal CHADS2 awareness would prevent maybe 2% more strokes. Universal awareness of an optimal guideline with all the information and stroke treatment effects would prevent about 10% more strokes, but these effects are marginal. We find that guideline adherence, if doctors complied exactly with the CHADS2 score, this would have a much larger effect than just awareness. And the reason is because once doctors become aware of the CHADS2 score, there are still far from perfect adherence. There are still many, many cases where they don't do what the CHADS2 score says, and our estimates of treatment effects say that generally they should. Okay, if they did what the CHADS2 score says, they would prevent many more strokes. And in fact, if they did what, they would prevent about 10 to 15% more strokes. If they did what an optimal guideline says, we consider various other optimal guidelines, they would prevent 20 to 40% more strokes for the same number of bleeds induced. Another way of thinking about this variation is we can think about an efficient frontier where we ask how many strokes are prevented and how many bleeds are induced if you order patients by a given rule, random CHADS2 score or some optimal treatment effect ratio, and you go from treating 0 to 100% of patients. So this is kind of a way of ranking different rules while being agnostic with respect to the weights attached to strokes and bleeds. What you see here is, so the CHADS2 score is much better than a random rule. A rule based on all the information and stroke treatment effects is much better than the CHADS2 score. It gets you fewer strokes and fewer bleeds induced. A rule using all the information about the ratio of stroke to bleed treatment effects does a little bit better still, but even just using all the stroke treatment effect information does pretty well. Okay, in the interest of time, I'm gonna skip over that. One more thing I'll just tell you and then I'll conclude. There was a new guideline after the CHADS2 score, the CHADS2 VAS score, which introduced one more variable to the CHADS2 score, which is vascular disease. Vascular disease was given a weight of 1 point. Vascular disease does predict stroke treatment effects, but because it was given a weight of 1 point rather than 0.1 points, it was actually given too much weight relative to the other variables in the CHADS2 score, and it actually led to a guideline which in this efficient frontier sense is worse than the existing CHADS2 score because they added another variable but gave it too much weight. All right, let me wrap up. So doctors are sensitive to the CHADS score and to bleed risk, but not much else. There is nonetheless huge variation in who doctors decide to treat that doesn't seem to be well explained by treatment effects. Doctors respond modestly to guidelines. In terms of guideline design, adherence to existing guidelines improves outcomes. adherence to optimal guidelines improves outcomes even more. The natural question then is, how can we improve adherence? There's a number of options we could consider. Education campaigns, basically integrating these recommendations into electronic medical records, making it harder for physicians to depart from what the guidelines suggest. So either having direct financial incentives or hassle costs when physicians want to deviate from the guideline. And finally, just improving guideline credibility by generating further evidence about the validity of guidelines. It might push doctors in the direction of saying, hey, the more evidence accumulates that we see that doctors who adhere to guidelines do better, the more we should adhere to guidelines. All right, thank you.
Thanks, Jason. Timely, inconsistent with the prior reputation. Excellent. To discuss the paper, we have David Molitor now, and I'm starting to see some questions coming in through the Q&A. That's great. Just a reminder that I'll consolidate them and we'll ask them right after this excellent discussion.
All right, Jason, you'll need to stop sharing for me to.
Sorry. Just.
All right, does that show up all right? All right, great. Well, I am delighted to discuss this paper by Jason Avaluk and co-authors, where they go deep into the woods of telling doctors how to do their job. And so I'm going to just make a couple of, I think, kind of brief comments, but as kind of background for this really important and thought-provoking paper, there's a lot of variation in what doctors do. So there's a huge literature documenting that doctors vary in how they treat patients. They differ from guidelines, they differ from each other. And an important question is whether these deviations that physicians make, whether they improve outcomes. And even if they're kind of beneficial on average, are they actually as good as they could be? Are they optimal? And this depends crucially on counterfactual outcomes for physician decisions, which is often hard to measure credibly. So this paper makes kind of important strides in overcoming these challenges in the setting of physicians prescribing clot preventing drugs. And what they do is they focus on I'll call this a simple guideline, the CHADS-2 score, which is based on 5 patient characteristics. And from this score, there's a guideline that recommends either prescribing anticoagulant or not prescribing it. And then what the paper does is it uses innovations in machine learning combined in randomized control trials to estimate rich heterogeneity in treatment effects as a function of patient characteristics. Importantly, not only the characteristics that go into the CHAD-2 score, but also characteristics that are not incorporated into the CHADS-2 score. And what they find is that there is, the CHADS-2 score is, and those factors that go into it are important for predicting treatment effect heterogeneity, but so are many of the other characteristics that are not in the CHADS-2 score. So there's a lot of, potential benefits left on the table if all treatment decisions are based purely on the factors that go into the CHADS-2 score. Now, what they do in the paper is they compare physician prescribing choices in the wild, so outside of the RCT and in the Veterans Health Administration, and they compare them to the treatment effects that are predicted by this RCT machine learning evidence. And what they find is that physician prescribing choices correlate strongly with treatment effects that are predicted by the CHADS-2 scores. So that's the guideline that physicians know about. But physician prescribing variation corresponds little with the residual variation in treatment effects. Now, the question is, what does that mean? Does that perhaps that's because physicians simply aren't aware that that there are benefits to be had, and it could also mean that physicians are responding to some other dimension of treatment effects that are not captured in that machine learning residual score. So I'm just going to make kind of 3 comments about what the paper does and how to interpret it. So a first thing that the paper does is it uses treatment effect heterogeneity estimated in randomized control trials, and then it applies it to a different setting, the Veterans Health Administration. And as Jason mentioned, it's really important to kind of assess the external validity of these estimates. And kind of the main approach that the paper uses is, first of all, the documents, and I think this is really nice. They don't just use one RCT, they have 8 RCTs. So they can actually show that within those 8 RCTs, that machine learning heterogeneity estimates treatment effects from a subset of trials accurately predicts treatment effects in another trial. And then there's a question about, well, the patient population in the VHA may be different from the RCT population. And so they talk about how the distribution of characteristics in those two populations has a lot of overlap. And Jason also showed this new result comparing the RCT estimates to these OLS estimates in the VHA. But I just wanted to suggest one other simple thing that I think the authors could do that would be very closely related to the validation within the RCTs. And that is simply when doing the validation of kind of within the RCT sample, they could simply do the validation, weighting those regressions by basically reweight the RCT population to look like the VHA population. And the idea is that the RCTs might be very good at predicting treatment effects in other RCTs, but only among some cells of characteristics. And maybe it's really bad at predicting outcomes for the types of characteristics that are prevalent in the VHA. They could just look at that directly by doing the same validation exercise and simply adding weights to, I think, to those regressions to make the RCT population look like the VHA population. All right, second thing is, how do we interpret the fact that doctor variation in physician treatment choices appears to be largely unresponsive to the machine learning estimates of treatment effect heterogeneity that are not contained in the CHADS2 score, so this residual variation. And to think about this, I think it's helpful to just remember, what does machine learning heterogeneity analysis actually capture? So machine learning heterogeneity analysis is meant to avoid capturing spurious heterogeneity or overfitting. So it gives you kind of internally valid estimates of heterogeneity. It, of course, may miss important heterogeneity captured by unobservables. So there are factors that physicians might be responding to that are of benefit to the patients that are not captured in the machine learning estimates because those characteristics aren't codified. But I think what's important is that machine learning may also miss heterogeneity with respect to captured observables. And this is just because machine learning typically is agnostic. It's trying to find a needle in the haystack. And if it fails to find the needle, that doesn't mean the needle isn't there. That simply means that it failed to find it. And so it's possible that one of the reasons why physician choices don't relate to this particular machine learning estimate of heterogeneity is simply that the machine learning, that there's some other dimension of heterogeneity captured by observables that the machine learning algorithm failed to capture. I think there's a direct way to look at this, which is that in the VHA data, you could build an explicit model of physician treatment choice as a function of the patient characteristics that are also codified in the RCTs, and then just use that as a score. You basically have a score about how physicians in the VHA treat patients and see if that score predicts treatment effect heterogeneity in the RCT registry beyond the CHADS2 factors. All right, and then the third thing I wanted to mention is that I think the paper, it would be helpful if the paper did more to discuss uncertainty and standard errors. So there, there's a lot of really nice analysis showing that at least on average, treatment effect heterogeneity captured by the RCTs is predictive of treatment effect heterogeneity in other RCTs or even in the VHA setting. But there are I don't know if these are large or small standard errors on those estimates, and it would be helpful to have an explicit discussion of that. And I think that's important because when you relate physician choices to these machine learning estimated treatment effects, you're basically regressing physician choices on treatment effects that are themselves estimates. And so the standard errors on that relationship might be sensitive to the amount of error in the machine learning estimation step. And it just wasn't clear to me how much uncertainty there was, or if that's something to be concerned about. And I think where that really is important is when you're doing the simulation. So the simulations basically take a particular machine learning measure of treatment effect heterogeneity. You can sort patients by those that get the least to the benefit to those that get the most. And then you can kind of calculate how much additional benefit would you get following one algorithm versus what, for example, what the physicians do. And this graph has no standard errors. There's no confidence interval. And it's not even clear to me if the confidence interval around these estimates is symmetric, because it's a function, I think, both of the ranking, the ordering of patients, which patients get treated first, and also what is the true treatment effect for each patient. And so it would be helpful, maybe if not for the whole curve, maybe if there are some kind of pivotal estimates that you look at for your simulations to say something about what the confidence interval would be around those claims. Okay, so just to wrap up, this paper shows that both physicians and machines deviate in what they recommend that you do from simple guidelines, but they, at least in some cases, they appear to deviate in different ways. It's important to know why they're deviating in different ways, although perhaps the burden of proof is on physicians to actually prove that they're the ones generating benefit on the margin. And I think this paper also shows that advances in machine learning combined with RCTs, plus perhaps electronic medical record systems, could allow for the use and adoption of more nuanced guidelines by physicians.
All right, thank you, David. And so we will now open it up to 5 minutes of discussion here. And we've already had one question on the role of time trends in the analysis answered in the Q&A. So for the interested party, see Layla and Jason's responses there. But there's another question there asking about whether you actually tried to explain the adherence of doctors and which doctors were providing better or worse treatment and why that happened. Sort of, you know, it's not orthogonal, but it's still sort of related to the underlying kind of average effect of the treatment guidelines. So you guys looked at that at all?
Yeah. So I would say a few things on that point. So first, just a big picture comment on one of the things that Dave said is the way that I see this paper is not, oh, it's the economists telling the doctors how they should do things. I see it much more as there's an active debate among doctors about the right way to treat this. Some of the doctors are saying, oh, it should be much more like what our estimates are saying. And other doctors are saying, no, we should do things this other way. And our evidence is buttressing one side of that debate. So on this explicit point, we did look at the variation in adherence across doctors, and it's big. Like we see some doctors adhere to the CHAD score, I think it was like 20% of the time is like the 90th percentile in one way. Some doctors adhere like 80% of the time, right? So there's lots of variation in adherence. Most of that can't be explained by the observables in our data. We have some observables that we can point to where we know there's big departures. So for example, age is one, and this is an example of the phenomenon that I was just talking about, where there's been a pretty big medical literature about, like, it's been observed before that physicians are much less likely to treat with anticoagulants older patients. Many doctors think that this is a mistake. Our estimates of treatment effects suggest that from a treatment effect perspective, it appears to be a mistake. Now, age also impacts the benefits of treatment conditional on treatment effects, although age means that the benefits of, like, it curtails equally the impacts of strokes and bleeds in a certain way. I shouldn't say equally, but the fact that you have fewer life years left to live is true both for strokes and bleeds when you're thinking about each of those. So I think the upshot there is age is something where there's an active debate about that. Our results further strengthen the people who are saying, yes, you should be treating more the older patients. And then there's lots of other variation in adherence that's just not explained by observables in our data, where we would conjecture that it's things like, you know, whether you're trained, what patients have you seen in the past, just differences in practice style where physicians have beliefs about which patients will benefit, but those beliefs just aren't supported by the existing treatment effect evidence.
Great. Well, I'll take my prerogative as chair. I had a question, well, a couple questions, but I was thinking about the fact that if you were to try to implement your approach, you know, one version is just there's this black box going on behind the medical record, and then there's the score, and that might be convincing to some, but certainly has caused consternation, and often physicians want some vague clinical sense, even if it's aggregating up these scores in a way not unlike the CHAD score. Have you looked at whether or how much of your causal trees could be built into basically redoing a score in a way that looked like the clinical score or a version of the clinical score that you had today? Or does a lot of it have to come from some complicated nonlinear function that's going to have to be mysterious?
Yeah, one of the things, I actually think I removed the slide, but in the longer version of this presentation, we do exactly this exercise where we're basically like, hey, imagine you were constrained to have a really simple risk score. So for example, imagine you actually just took the CHAD score, and instead of having the weights of 1, 1, 1, 1, 1, 2, you had like other integer weights or something. How much better could you do? How much better could you do with other scores? And the answer is you can do substantially better than just the CHAD score. But again, even adhering to the CHAD score seems like it would be a big improvement over the status quo.
One other just quick question, then we can get our time back. But you have an advantage here that you get this really cool large scale clinical trial data because they've run so many clinical trials. Do you have any thoughts or comments on if we're going to take, if we're going to have you run medicine? Which
no, I think that's a good idea.
There clearly, but obviously the structure of clinical trials, or not obviously, it seems like the structure of clinical trials in general would need to change. How often do we get 8 clinical trials that are comparable that we can put together to do this kind of exercise? Do you see this being feasible given your 6 years of effort that we can't just use causal?
No. I think my view is increasingly that there is enormous social returns to clinical trials, and that in fact there's just too few of them, and so that's a big topic. There's a variety of things we could say about that, about trying to make it less expensive to recruit patients, trying to give bigger incentives to do trials. But I think one of the main takeaways from this paper is that like the value of getting more and bigger trials is extremely high. That it's like we can really learn a lot from them that is just hard to learn in other ways. And so I'm increasingly thinking that is just an extremely worthwhile social investment, even in cases like warfarin, where it's like, this is something where relative to most things, we've done a lot of trials, but like, I think, having twice as many trials or much larger trials, that is beneficial. The other further point is just, okay, for research, we'd like to be able to aggregate them all. The way medicine works is it's very siloed, it's changing slowly, but it's like, it took us a long time to even put these trials together, given that someone else had already constructed a similar database. So it's like, and we're trying to apply for other trials to add to this, but I think there's enormous social benefits of like streamlining the process of aggregating all the trial information in one centralized microdata. And there's other people like Harlan Krumholtz, my colleague at Yale, who are working on that, but more needs to be done on that.
Great. Well, thanks. So we're off to a great start. Let's hopefully don't mess it up, Ziad. Next up, we'll have Ziad Obermeyer talking about measuring moral and behavioral hazard in healthcare. And you have 20 minutes, and then Julian will be discussing it.
Thank you. And I'll just, as I'm getting set up, say that based on everything I know about Jason and Layla and medicine, putting them in charge would be good for everyone except Jason and Layla. I'm going to switch gears and instead of thinking about physician decision-making, I'm going to tell you about our paper on, which is largely about patient decision-making. And it starts with the observation that all of you know, both as consumers of healthcare and scholars of healthcare, which is that cost sharing is everywhere and getting more and more common as a way to reduce costs. And I think it's obvious that because not all use is optimal, if there's overuse due to moral hazard, among other things, that institution of cost sharing might be efficient. But as some of you know and have produced more and more literature, it suggests that these cost sharing measures can also have the effect of reducing health. And that one of the main mechanisms has been proposed there, both in the clinical literature, but also increasingly in the economic literature, where it's termed behavioral hazard, is that patients might misperceive the benefit of that care, and so not be making an appropriate trade-off of the benefit relative to the costs. And I think if you look at that growing literature as a whole, Exhibit A, the thing that people point to in that regard is that patients just seem to cut back indiscriminately on healthcare when the price goes up. So when we are fortunate enough to observe a price shock, we see that patients cut back on care that looks good, care that looks bad, and that's a finding that was noted originally in the RAND health insurance experiment and basically every study of price shock since then. There were one very salient example that many people were quite struck by, which is a randomized trial where patients were they were given heart attack medicines for free in the hospital right after they had a heart attack. And it seems that despite the fact that those drugs would have been very valuable if you've just had a heart attack, patients do seem to be elastic with respect to price, even when it seems like it's very worthwhile for them to pay the extra $10 or $20. So the natural question that, as I've learned, economists seem to ask much more than doctors is, are those cutbacks actually errors? And I think it's very tempting to think so, but there are also a couple of good reasons to think that we might need to consider that more carefully. The first is that, as I think Jason and Layla's and Diana's paper shows, what's high value to one patient might not be high value to another patient. Mammograms are low value on average, but to a woman with breast cancer, quite high value. And combined with that, patients actually know a lot about their own risks, their own preferences, what drugs have side effects, et cetera. There's a lot that we don't observe. And so fundamentally, in judging patient error, we face the similar problem that the previous paper faced, which is that, well, who's right? When we see a decision that looks ill-considered to us based on the data that we have in Medicare claims or electronic health records, are we right, or is the decision maker right? And I think that the key thing that we're trying to focus on in this paper is who's right really depends on what happens to health, not just what happens to demand. The two challenges, though, to studying that I think have plagued this literature are, first, that obviously prices are not randomly assigned. Largely, they reflect utilization. The price that you pay for care today depends on how much care you've consumed yesterday, either implicitly or explicitly, and all that is inextricably tied up to someone's prior health and their choices. And so you need that randomization that you got from RAND, from the Oregon Health Insurance Experiment, from lots of the papers that you all know, to solve that and break that link between someone's health and the price that they're facing. But the second problem is that where you have that clean identification, you are generally underpowered for detecting the health outcomes that you really care about. And so very back of the envelope, base rate of mortality at age 65 when you enroll in Medicare is about 1%. To detect a 10% change, you need hundreds of thousands of people. And when you look at the sample sizes, even of RAND, which in today's dollars is like, what, $250 million to do the trial, you're orders of magnitude less than that. And that's why we end up with these proxy measures, looking at the demand response and trying to infer whether something was high value or low value. Okay, so in our paper, what do we try to do? Well, we're working in Medicare Part D, the prescription drug benefit, and we're trying to isolate some health effects of cost sharing. And we're going to use, with one important modification, something that has appeared in the literature before, which is the fact that depending on which month you're born in, and thus which month you enroll in Medicare in the year that you turn 65, you're going to face different prices at the end of the year. And I'm going to get into that in a second. But just to give you a sort of high-level summary of the results, that enrollment month is going to vary prices by about, it's going to increase or decrease prices by about 35%. That's equivalent to about $10 per drug that a person is filling. And that shock results in, in our population of interest, the people who are compliers, you can think of them, the people who face these price changes, that's going to really increase mortality by a kind of dramatic amount, over 30%. When we try to make sense of that, we're going to look at what exactly patients are doing, which drugs they're dropping. And they seem to be dropping drugs that are high value on average. Now, am I making the same mistake that I just tried to convince you of was a mistake, was saying, on average, these things are bad, but what about the person? When we actually look at the people who seem like they would benefit the most from those drugs, they are at least as likely to drop the drugs that benefit them as people who would not benefit. And could this be liquidity or budget effects? Sure, but we note that it also happens in rich zip codes just as well as poor zip codes. And the final thing we do to make sense of this is to try to look at, when faced with this really, really hard choice, rank ordering all your medications, deciding how many to fill, what do patients do? Well, they make very crude decisions. For example, an appreciable number just fail to fill all of their medications, no matter how many medications they used to be on, in response to these price increases that don't seem to justify that decision making. Okay, let me dive into the details, but before that, you'll note that all of this seems like a kind of fairly standard causal inferency economics type paper. And so I'm just going to flag the points where machine learning has really helped, and I think really made the paper and at least helped it detect an effect. One is in isolating that variation in prices, our first stage. And the second is isolating, or at least making a guess as to the potential benefit that people are going to get from their drugs. Okay, so in the Part D literature, there are many price shocks that people have studied. The one that we're using is the fact that as you spend more and more money over the course of a year, prices shift discontinuously. So for example, once you hit $2,500 of total spending, not out of pocket, but like the total value of drugs, your price, the co-insurance rate that you pay for drugs goes from 25% to 100%. So there's a while when you're paying the full price of your drugs. But those limits are not prorated in the year that you enroll, and the month that you enroll is the month that you're born. So you can enroll in February, and then you face that whole year. You have the whole year to spend $2,500. Or if you are born and enroll in September, you have much less time to reach that same threshold. So we're going to be looking at the end of the year because that simplifies the kind of complex calculus of current price, the spot price versus the future price. And so we're going to look at December of that first year, the year that people turn 65. I'm going to show you this plot of the arm of the plan, like whether that initial 25% price or the so-called donut hole, the coverage gap where you're paying the full price as a function of enrollment month in that first year. So what you can see is this very nice, note the y-axis is kind of truncated here. It goes from 12% to 100%. But what you can see is that as enrollment month gets later and later in the year, fewer and fewer people are reaching that coverage gap. So fewer and fewer people go into the donut hole. And what you see is that these are the kind of people who would have gone into that coverage gap and paid 100%, but are instead paying 25% thanks to the late month of the year in which they are born and thus enroll. So what we're going to do is essentially just compare horizontally across this, and comparing early to late year people, we're going to find that the early year people are facing a higher price at the end of the year than the later year people by virtue of the month in which they're born and thus the month where they can enroll in Medicare. Now, there's a big problem for us, which is that we're fortunate that enrollment month looks like it's unrelated to health, to spending, to lots of other things. So we test that pretty carefully. So we do have a as good as random shock to price at the end of the year, but that shock is still a very blunt tool. So there's still lots and lots of price differences within an enrollment month. So as a very obvious example, 70% of people, no matter what month they're born, don't get close enough to that first $2,500 threshold to be affected. So these are kind of non-compliers. It just doesn't matter what month they're born in. For the next 30%, there's still a lot of difference. So for example, if I told you on day one, I see person A filling 5 drugs versus person B filling 2 drugs, you can make a pretty good guess that that first person is going to be more likely to end up in the coverage gap than the second. But it's not a simple function. So what we really want to know is how much would they spend in a year? And that would help me compare a high spending February person to a high spending September person, not be kind of accounting for this huge heterogeneity and imprecision in the price. But of course, you can't use the realized spending because that's endogenous to the whole enrollment month and choices and response to the cost sharing thresholds. So our insight is to frame this as a prediction problem where we can use machine learning. So what we want to do is get some counterfactual prediction on spending. How much would this person spend in a year if they were born in a given month and facing a given cost sharing regime? And one huge advantage is that there's this whole separate population of Medicare people who are eligible for Medicaid, who are different, of course, from our main sample, but who don't face any cost sharing. And so what we do is we train a machine learning algorithm to predict spending from enrollment month to 12 months later in that population. We verify that it's accurate, and then we use that function to generate our counterfactual predictions in the main sample. And then we basically just control for that by interacting it with enrollment month in our first stage. We're not imposing anything. We're just giving that first stage model the option to use the predicted spending. And that's going to dramatically improve precision. So let me just actually show you what I mean, because it's a lot easier than words. So the y-axis here is the co-insurance rate that someone is paying in December, the price. And the x-axis is that enrollment month. And in the low spenders, the people that we predict to be in the bottom 70% of spending, there's no effect. So these are people who are far from the threshold. They're not facing any difference in price. Here are the median spenders, the people where, based on our predictions, we expect them to fall into the donut hole. And what we find is that here price is decreasing in enrollment month. Now, there's one part of the plan that it's a detail in a sense because it's only 2% of people, but the plan actually reverses. So once you make it through the donut hole to about $5,500 or $6,000, then you go back to paying nothing for your drugs. So this is a really nice little check on our setup because here in these top 2% of people that we find that flips. And so enrollment month, increasing enrollment month is going to increase the price that you pay because you're still in that coverage gap and you haven't broken through to the far side of the donut. So this all lets us get a lot more precision on the prediction on price in our first stage. And now let me just show you kind of in these three bins our quote unquote reduced form mortality result. So in the low spenders, there's basically no result. So mortality is flat in enrollment month. In this middle group, mortality is decreasing along with price. So early month, higher price, higher mortality. And again, as a nice check here, we see the exact opposite trend in these high spending people. Higher price, higher mortality, even though that's coming on different ends of this enrollment month spectrum. So what we can do is so that was using basically 3 bins, but we don't have to use these coarse bins. We can use very small bins of this predicted spending. And that's what we do in our 2-stage setup. And here's what we find. So monthly mortality, that December mortality that we're interested in, is going to increase by a very small number of percentage points for every 1 percentage point of coinsurance. Remember, we're dealing with 65-year-olds. We're only dealing with 1 month here, so the numbers are low, but let's scale this. So let's look at those top 30% of people in terms of our ex-ante predicted spending, people who have a chance of coming close to the threshold and being affected by them. Their median coinsurance change is 11 percentage points. So that's, as I mentioned, $10 per drug. And if we just multiply all that out, so the mortality effect times the median coinsurance change, we get a change of 0.05 percentage points in mortality, which is that 32% increase that I mentioned. So it's a small number, but mortality in 65-year-olds is also a small number. To put that in context, if you use a standard life year valuation of $100,000, these 65-year-olds who are non-disabled, who have just enrolled in Medicare, are behaving as if their life expectancy is 1.3 years. Just kind of for context, it's much more. It's about 18, 19 years. For healthy 65-year-olds, for people with heart disease, it's like 13, 14 years. Or at average life expectancy, they're acting as if a life year is worth $6,700. Couple of things this could be that we want to rule out. So is this some failure of our exclusion restriction? So one reassuring thing I've already showed you is that sign on mortality is flipping as a function of predicted spending. So it goes down in enrollment month for the middle group and up in enrollment month for the high spending group. We can check this in year 2. So there's no effect in December of year 2 of enrollment when all these prices are the same. In our dual eligible sample that faces no cost sharing, there's no relationship between mortality and enrollment month. And when we look at other channels for this effect, inpatient spending, outpatient spending, other parts of Medicare does not seem to change as a function of enrollment month. So all these things I think are hopefully reassuring. There's nothing else going on. There's another explanation, which is that these people might have just died soon anyway. They're just like sick people, even though they're 65 years old. When we follow out monthly mortality over the next year, we do not see the decreases in mortality offsetting this increase that we'd expect if these people would have died in a few months anyway. And then, as I mentioned, could this be budget constraints, liquidity? It certainly could be, and we have trouble ruling that out because we don't observe individual income. But what we can do and test is that in high income zip codes, there is no difference in the treatment effect. There's no heterogeneity in how big of an effect we get on either mortality or spending as a function of zip code income. So I'll tell you a couple more things just to make sense of this. This is a big effect, and so one just reality check is, what are patients actually doing? Well, they're dropping drugs that seem to really matter for mortality. So 58% of our sample is on a statin. Statins in clinical trials have about a 25% mortality reduction. And people are cutting back, in this complier group, the top 30%, about 11% on their statins. And so just by kind of like using the average effect and the cutbacks, we'd expect a 1.7% mortality increase from that cutback, just applying the average effect from the clinical trial, the degree of the cutback. And it turns out we can do this for 4 classes of drugs where we know the mortality effects from clinical trials, and just adding those up, the degree of cutbacks, gets us to about 1/3 of our effect size. So we're in the right order of magnitude, just adding up these effects. And then we can also look at the fact that, it's not just these drugs are high value on average, but the people who dropped them, it would have been very high value for them. So we use machine learning to predict, again, in that other sample, who is at the highest risk of heart attack and stroke. And that generally seems to correlate with the treatment effect. For statins, we know that's true based on lots of different measures of the treatment effect. But what we find is that our highest risk 1/3 cuts back a lot more on statins than the lowest risk 1/3. And we find similar results for drugs for diabetes, drugs for COPD. Last fact is that when patients are faced with that price increase, a substantial fraction of them are actually just dropping all of their drugs. So this is just the kind of descriptive data, number of drugs that people fill on the x-axis. It's a histogram in February enrollees versus September enrollees. And what you can see is that there's this kind of fairly big difference in people who are filling no drugs in December. And when we look at people who are on more drugs to begin with, people who have filled at least 4 drugs in their first month of enrollment, that gets even bigger. So you can imagine that if people are dropping all of their drugs, that's actually just mechanically going to result in bigger cutbacks for people who are sicker and on more drugs to begin with. So in closing, I think that our results contribute to this literature on behavioral hazard. So cutbacks in demand are not a great proxy for welfare because they're just demand and they don't capture these health effects. And the life valuations that we're finding at least seem low for optimal decision making. A key part of getting the precision that we need to detect that came from that machine learning enhanced first stage, which I think highlights a point that many have made, which is that the first stage is essentially a prediction problem. You don't really care causally about what's shifting that first stage as long as it's random. And so more precision is worth a lot. This raises a lot of behavioral questions about what the mechanism is. Why are people dropping all drugs? Is it that costs become salient? Is it because the calculation is hard, memory? Are people just giving up? Lots of interesting questions there. And I think the last thought is that when we're thinking about cost sharing regimes, we should think about regimes that not just minimize costs, but also minimize the health effects.
Great, thank you, Ziad. Discussing the paper, we have Julian now. Take it away, 10 minutes.
All right, thanks. I'm very excited to discuss this paper by Ziad and his co-authors. So this study, it combines detailed medical data and machine learning prediction models with a nice instrumental variables research design to answer some really important questions regarding patient behavior and healthcare policy. So the analysis I thought was very clever. The paper is clearly written. I learned a lot, and I encourage everybody to read this paper when it becomes available. So let's hop right to it. These graphs from the paper convey nicely how identification works in the study. Basically, the authors compare 65-year-olds who enrolled into Medicare in different months. So for example, they compare a 65-year-old who enrolls in February to one who enrolls in August. And because Medicare does not prorate benefits in the first year, these two otherwise identical individuals will, in expectation at least, face different prices at the end of the calendar year in December. So implementing this design is a little bit tricky because of Part D's crazy pricing structure, but I was convinced that the implementation was successful and well done. All right, so if we look at the left panels, here we see, as Ziad showed us, that the February enrollees who are expected to have sort of intermediate to high expenditures face higher co-insurance rates than the August enrollees. And there's also a corresponding difference in the mortality rates. By contrast, if we look at the right panels, we see that February enrollees with very high total expected expenditures face lower coinsurance rates at the end of the year and have lower mortality rates. So overall, I thought these graphs are very compelling. Now, the main identifying assumption of this paper, that variation in birth month is as good as random, seems very plausible to me. So I had only one thought here, which is that the authors assume that all of the effect is driven by differences in prices. And I was wondering if it's possible that differences in the timing of changes in insurance matter as well. All right, so when you sign up for Medicare, this potentially involves several different changes, such as you might be switching healthcare providers, for example, and patients may need time to learn how to navigate their new prescription drug coverage. All right, somebody who enrolls in February has had more time to learn than somebody enrolling in August. Now, this learning process may have effects on utilization over and above the changes in prices. Now, I don't think that this effect can be large. All right, so first of all, the authors, I don't think Ziad mentioned this, but they throw out new enrollees who enrolled after September, who are still learning and ramping up their drug spending. But on top of that, to the extent that this learning factor matters, it can't be too large, because otherwise the authors wouldn't get different results for people who are expected to be in the coverage graph versus those who are expected to be in the catastrophic phase of the insurance plan. Nevertheless, it was something that I wanted to hear the authors talk about a little bit more in their paper. Next comment I'd like to talk about briefly is mortality displacement, or sometimes called harvesting. All right, so this is the concern that the excess mortality that the authors find in December might be offset by lowered mortality a few months later. And if that was the case, it would indicate that it was only very frail individuals who died. But the authors show that there doesn't appear to be lowered mortality in the second year. We're not finding any significant effects in these months. And so my second comment really here is quite minor. It's basically just to expand on this a little bit. I think it would be helpful to show the effect on cumulative mortality, not just month-specific mortality, to really hammer this point home. So there are some negative point estimates in this table, right? So I think in June and November, these are probably offset by the estimates in the other month. But if you showed cumulative mortality, that would really make that point clear. The second suggestion here is a lot more involved. I mention it only because these guys are machine learning gurus. But the suggestion is to think about building a machine learning model that predicts life expectancy for the individuals in their Medicare data set as a function of their characteristics. Right? They could then use that as an outcome variable, and that will just give you a direct estimate of life years lost. My third comment is about the size of the point estimate. So the authors talk about this at length in the paper. Right? It's big. All right, so 35% increase in out-of-pocket costs increases monthly mortality by 32%. So I don't think this point estimate is crazy. And so I want to just spend a few minutes here talking about why. So one thing I did want to mention first is that I do think the authors could emphasize a bit more that their standard errors are quite large, right? So the headline estimate is an effect size of 32%. And I didn't see the confidence intervals for this estimate in the paper, but when I calculated them, I got a range that suggested this estimate is consistent with an effect as small as 2.3% or as large as 62%. Right. So the first thing is that the author's results are also consistent with more modest changes in mortality. All right. So that said, I do believe that the mortality effect here could indeed be very large. So they have this nice table in their paper, and they point out that we know from the medical literature that a lot of drugs these patients are cutting back on, like statins, have been shown in medical trials to have enormous effects on mortality. All right, so I do think it is quite reasonable and not necessarily surprising that large mortality effects emerge if people stop taking these drugs. All right. And sort of in that vein, there are also several studies that look at the effect of health insurance on health. And a large number of these studies do find very large mortality effects. All right, so I think the study in this literature that's actually probably most closely related to this one is my own. So I'll just mention that quickly. So Jason Hudd and I estimate the effect of the 2006 introduction of Medicare Part D on the mortality of people who just became eligible for Medicare. So it's really actually pretty much the same group that's being studied in this paper. And we calculated that among the compliers, so those gaining prescription drug coverage, that reduced annual mortality by about 10%. So it's not entirely straightforward to compare that estimate to the estimate in this paper, but I think it's safe to say that it's certainly inside the confidence interval, right? And also we found that our mortality effect was driven by changes in cardiovascular mortality, right? So again, that lines up nicely with what the authors are finding here. My fourth comment is about the falsification tests. So the authors do two of them in the paper. So one is they rerun their analysis for patients who are 1 year older, right? So age is 66. And then also they run it for dual enrollees who are at age 65, but they always face low prices. And so they shouldn't be affected by this differential enrollments here. And so they passed the second falsification test for the dual enrollees, but the results are a little bit more mixed for the people age 66. All right. So, and in fact, if we look at the people who are in the catastrophic phase of the insurance plan, right, the point estimate on mortality here is significant and about as large as the one from their main sample that uses 65-year-olds. So I think that's a little bit concerning, or at least needs a little bit more discussion. I'm actually not even sure if this is necessarily a completely 100% valid falsification test, right? It's possible that maybe some of this is real, right? If we think that there's long-run dynamic effects of the initial enrollment, then maybe that's actually even showing up in the second year. So I think one way to get at this a little bit is to redo this exercise for older ages, people like 67, 68, and see what comes out of that. That might help shed light on what's going on, or whether or not, you know, this estimate here is just a fluke. And so the final comment I had is about the policy implications, right? So I agree completely with the motivation that Ziad started off with, right? So I mean, deductibles and co-payments, these are very common features of health insurance. And it's really important for us to understand what effects they have on patients. All right. So the authors argue that, you know, from what they're showing here, that increased cost sharing can cause people to make serious mistakes. Right. Although they also take pains to note that their results are consistent with sophisticated behaviors like, you know, switching from branded drugs to generic drugs, for example. So my comment here is just a little bit about framing, which is that, at least from my perspective, even if behavioral hazard wasn't present, it's not clear to me that it's very socially desirable to use deductibles and coinsurance to deter the consumption of prescription drugs. All right, the marginal cost of a lot of these drugs, like statins, is what, 10 or 20 cents a day. All right, so arguably, you know, prices should be low anyway, even if we didn't have this behavioral hazard effect. So I just sort of see this point as basically reinforcing the author's suggestion that we really reconsider how we design these price schedules. So I think that was my last major comment. So I'll stop here and then let Ziad take additional questions from the audience.
Great. Thank you, Julian. Let me, there's one question that's come in, and you can maybe respond to the comments in this question as well. There's basically a question which has a bunch in it, but I interpret as asking, how are you dealing with the heterogeneity in plans along a whole bunch of other dimensions that are unrelated to average cost sharing?
Yeah, so in all of our estimates, we've got planned fixed effects in. So nominally, in a dumb way, we're controlling for it in the whole setup. We don't have a lot besides that to say about the different plans, and I think that, you know, to the extent that those other plan design factors have things that are correlated with price, it's hard to tease those apart. So we can only really see the price, but to the extent that that's captured in time invariant things, then we should be able to take that into account with the fixed effects. And Julian, I just wanted to thank you for the very thoughtful comments and for not being deterred by the fact that I did not send you the present. I'm amazed that you managed to have so many thoughtful things to say, despite my best efforts. So thank you. Were there other questions, John? Sorry, I'm just pulling up the Q&A.
They're not. I had a question. I'll take my prerogative.
Oh yeah, please.
Jump in. But I may have missed this. You talk about no effects on spending, but it seems to me that you could also look for the intermediate effect before you die, which is hospitalizations specific to the meds, and that's something I didn't see much focus on. But have you thought about doing more on that? And then just one other thought on, I understand why you're looking at sort of how people treat their life years, But another interesting way to look at the effect of this might be because you have older people on the same meds. I mean, effectively think of an exercise of matching people that are older and saying effectively, how old would these people have to be to get the mortality rates if they were adherent to their meds? So you're basically turning these 65-year-olds into, I don't know what it is, 89-year-olds or something like that by virtue of, just two questions or comments.
I really like the kind of the premature aging idea. I think that's a really nice way to state the results. All of the part A and B results are hard because, you know, we're even with all of the bells and whistles, we're underpowered in the whole population, of which I think a third are standalone Part D plans. So we lose another third of our sample when we go down to look at hospitalizations and physician spending. So it just proved hard to find much going on there. But yeah, we tried. We didn't find much.
Any other questions from the audience participants? All right, well, we'll keep moving. We're gonna have an open discussion at the end here if we have time. So I will then turn over Dan Zeltzer, who is giving our last talk from tomorrow, from the 4th. So thank you for joining us in the middle of the night, and look forward to it. And you'll have 20 minutes.
Then you're muted.
Yes. Okay, thanks for joining me in ringing in January 4th here in Israel. This is called Why is End-of-Life Spending So High? Evidence from Cancer Patients. And this is joint with Liran Einav and Amy Finkelstein, and with our colleagues in Israel, HMO, Clalit, Tzvi Shir, who was assisting us with this project, Salomon Stemmer, who is a practicing oncologist, and Ran Balitzer, who these days fights coronavirus, but in usual times he heads the research and innovation arm of Clalit. So we ask the big question of why is dying so expensive? It's a well-known fact, and there's a sort of a live public debate about this fact that we spend a lot of healthcare dollars on those who are just about to die. So 7% of total US healthcare spending is in the last 12 months. A quarter of Medicare is in the people who are in the last year. And you might think this has to do with, you know, the quirks of the US system, spending a lot of money on healthcare. That is not true. This is the effect that is true across the developed world, as it has been already shown. Actually, when we replicate spending concentration in Medicare and in Israel, they look almost exactly the same. So the share of spending relative to the share of dissidents in the population. And another thing you might think is that, well, and this has been also discussed by a paper by Einav and others, including Ziad in Science a couple of years ago, that you might think that this is sort of an ex-post fallacy where, well, we spend on people who are sick, the sick tend to die, but ex-ante, they all look the same. And that's not true either. Ex-ante, given conditional death probability, eventually dying is more expensive than survival. So in this paper, we ask why. We try to do this forensic accounting exercise of why spending concentrated on those who eventually die. And we focus on cancer in Israel, which is a useful context for several reasons. As I mentioned, I mean, Ran is in Clalit. He's been just talking to the New York Times last week, the interview about the benefits of having this integrated system for distributing vaccines. And it's really, we have a repository of data on more than half of the Israeli population with the EMR, and they really run the show by owning a lot of the hospitals. And so we have very good data for a large population. And specifically, cancer is a common and expensive disease. So it's the second leading cause of death in developed countries, and by far the most expensive per capita. It's true across these countries. And what is more, it has a very clear time where things unfold. So unlike some other diseases that are slow killers, we have a very clear date of diagnosis, after which there are major spending decisions to be had over a short period of time. And it affects finally a wide age range, so we can compare sort of spending on terminally ill patients that are young versus old, which is not easy with other diseases that mostly affect the elderly and the very old. So we link this data and we kind of start this largely descriptive exercise. This is not a causal inference paper. What we do here is basically start with each patient's date of initial cancer diagnosis, and then we use rich patient history, which, as I mentioned, include a lot of variables, to predict one-year mortality. This is what we call the initial prognosis. And then we study spending conditional on this initial prognosis, sometimes decomposing sort of further by eventual mortality status. We call survivors those who survived the year since the initial cancer diagnosis, and dissidents those who did not. And I think two conceptual notes, we go into more details in the paper. You want to basically, I mean, what you really want when you think about efficiency and waste is to see how dollars affected mortality. Of course, we don't do it here because we don't have that kind of variation, and it's hard to imagine anyone having that at sort of the population level. And the other thing, which is with more nuances, when you study spending on predicted mortality, it's predicted mortality under current practice, not under the natural sort of course of the disease. So everything is a little bit squished. And you could go to the paper for details about how we think about that, but we still think this is sort of informative about what's going on in the course of treatment. So the motivating fact, as I mentioned, is that even among patients with similar initial prognosis, spending in the year post-diagnosis is much higher for those who eventually die compared to those who survive. And we use this framework to describe a series of aspects of this phenomenon. First of all, what types of services or what type of spending is elevated among dissidents compared to survivors? Are these the same services that generally are used to treat cancer, or a specific subset? What is the time path and dynamics of spending and risk, and how they're related? And what are the age patterns in spending, and what might this teach us about this spending concentration on the dying? So as I mentioned, the setting is Clalit Health Services. They cover more than half of the Israeli population. We have very low churn. It's less than 1% a year, so we observe people for a long time. They own a lot of the hospital, so we can go into sort of granular analysis to validate and check the robustness of some classifications, such as this is only the paper, but it's basically it's similar to the VA, I guess, in that it's kind of both granular and covers a large population, and it's sort of tightly linked to administrative death records, so we know exactly who died, even if they happen to move. Finally, the sample is all cancer cases for adults in 13 years ending in 2013. We have the not very restrictive requirement of continuous coverage. And this subset of cancer patients is sort of helpful for studying end-of-life decisions, because it is very risky to have cancer. They have a survival rate of 80%, so 1 in 5 would not survive the year. That's compared to 1.2 mortality rate, 1.2% mortality rate in the general population. Mortality is also front-loaded, conditional on dying within a year. A fifth of the patients die within a month, and they are far, far more expensive, 10 times more expensive than the average adult, and dissidents are more than 20 times more expensive than the average adult. So our initial prognosis algorithm is nothing special in terms of machine learning. It's XGBoost. We try various things. I mean, this predicts fairly well mortality. So it's what is called an expressive method. It deals well with interaction and nonlinearities. You throw a lot of data in it, and we do all the usual shticks by split testing and doing cross validation to tune the hyperparameters and downsampling to get sort of class balance. And it works fairly well. It's very well calibrated, even on stuff that we didn't sort of specifically calibrated it on. And it doesn't seem to overfit too much. And of course, we use only data up to the date of diagnosis when we predict initial prognosis, including cancer type, which is known at the date. And some of the analysis I'm going to show you some interim predictions. Of course, at any point, we're going to use data up to the prediction and only use the test sample to show the analysis. So jumping right in, the results. So first, this is this basic fact comparing dissident and survivor spending. So on the x-axis, you have the initial prognosis, 1 year mortality risk. And on the y-axis, you have average monthly spending. So spending is always adjusted for survival duration. So this is spending while dissidents are still alive. And you see that it's twice as high roughly than survivor spending. Now to start, and of course, if you look at this scaled densities in the background, obviously the model is calibrated. So if you eventually died, you're much more likely to have had initial higher mortality risk. So to start comparing these lines, we need to reweight them. And we do this by essentially changing the measure on spending so that we reweight survivor spending by dissident risk. We also weight by a month since diagnosis because both mortality and treatment are front-loaded. You can think about it as sort of matching survivors and dissidents and following them to kind of have an apples to apples comparison. And then it allows us to go into sort of service level and start to decompose and do our forensic accounting. So here you see, starting from the left, basically in each of these groups, you have 3 columns. The red is dissident spending, the light blue on the leftmost in each group is survivor spending not adjusted for risk, not reweighted, and the middle one, the darker blue, is survivor spending reweighted. So you can see, indeed, adjusting for the difference in risk between eventual survivors and eventual dissidents does account for some of the difference in spending, but there remains a large gap that is not accounted by these reweighting. And the 3 groups of columns on the right basically show you a decomposition into 3 services or 3 groups of services: low intensity admissions and high intensity admissions that are basically defined. We define them in different ways. It doesn't matter, but this is defined based on the ward you're admitted to, when low intensity is things like internal medicine wards and high intensity are surgical wards, and all other services is outpatient chemotherapy and radiation therapy and all sorts of other things that cancer patients receive. And the main observation here is that elevated spending on dissidents is almost entirely driven. It's about 95% of the difference is explained by increased hospital use, particularly these low intensity admissions, which typically, are started as unplanned through the ED, have no major therapeutic procedures when we dive in chart data. And so these are the biggest difference. And this is not how usually cancer is treated. Actually, when it comes to what is the more prospective treatment, like surgical interventions and chemotherapy and stuff like that, that's not so different between these 2 groups. So it seems to suggest that low intensity admissions are sort of a main cost center that differentiates between dying and surviving. Now, another point we dive into is that cancer is a dynamic process, and we have these data on treatment that, as I mentioned, unfolds over time. And so to dive into that, we basically construct a sample where for each patient, we make a timeline of all the major clinical events. This could be surgeries or drug spells or radiation spells. And then we predict mortality at the start of each of these events, and we examine how changes in risk take place over the course of treatment and how spending changes. Now, it's important to know that this sample, of course, has attrition both into death and into remission, but arguably the patients still in treatment are when all the cost and spending decisions have to be made. So in some sense, this is an interesting exercise nonetheless, and that complements our previous exercise that looked at everyone. So first observation, this is looking at pairs of events and trying to compare what happens to the mortality risk during the course of treatment when patients exhibit different types of events. So on the x-axis, there is a 1-year mortality prognosis at the start of the previous event the patient had, and on the y-axis, you see the prognosis at the current event. And this is grouped by the different shapes and colors, different types of current events. And you can see that for most events, surgical admissions, drug therapies, radiation, and so forth, there's no marked change in mortality risk when you start them as a cancer patient. And this is in stark contrast to low intensity, often unplanned admissions that are associated with a marked increase of about 10% in mortality risk. So just starting such an admission is very bad news in terms of the predicted mortality. The other thing we can do is take these pairs of events and see how change in the predicted mortality risk is associated with a change in spending. And you can see And this is the different facets shows different levels or different ranges for the current level of mortality risk. And you can see that, starting from the left, there is a clear positive association between an increase or a decrease in mortality and an increase or decrease in 1 year spending going forward. And this is robust to, plucking out the current event. So it's not just entering hospital makes you more expensive. Even if you take the current event out of the calculation, you're just being treated more intensively as you become sicker in terms of your mortality prognosis. However, and I think in contrast to sort of this kind of folk notion that, there's an acceleration of risk of spending when risk increases that is completely senseless, it actually decelerates in the sense that if you go to higher and higher current level of mortality prognosis, actually this is a moderating factor and it weakens this association between increased risk and increased spending. So this looks somewhat more benign than this kind of caricature picture of accelerated spending. Another perspective can be gained, and this is a different way of cutting the data. So let me explain. We can just look at dissidence. So this is admittedly a very ex-post way of looking at things. But in order to study timing, we just focused on those who did not survive the year. And then again, grouping by the 3 types of services, we can look at how different groups of dissidents, different lines here stand for dissidents with different survival durations. So those very light lines in each of the facets that stand for different services are those who survive a shorter period, and darker lines are those who survive longer periods. And starting from the right, actually from the middle, you can see that these surgical interventions to remove tumors are very, for everyone, they get them in the first month. It's pretty uncorrelated with your survival duration. And then subsequently, you get all these other interventions, outpatient interventions like chemotherapy or radiation therapy. But actually, those low intensity admissions that we already mentioned are where the cost is and which associate with an increased mortality risk really spike sort of differently for each survival duration group. And a complement sort of picture to that is squishing everything to the right. And we can do that because we selected the sample to be just those who died. You could see that now when you count back from death, so now 1, 2, 3, counting from right to left is 1, 2, 3 months before death, which is again, admittedly an ex post measure, you could see that it's really the couple last month before death where you see this spike in low intensity admissions, whereas now these other services are not so much correlated across these different groups. So it seems that these low intensity admissions really spike just before death. So, I mean, we look at this picture and it basically suggests that there's a gradual shift, and we do more in the paper to dive into the specific procedures and validate it in other ways. But essentially the picture is that there's a gradual shift from fighting cancer through kind of curative care, through surgeries and therapies, to gradually, varying into maintenance care, which is basically very few sort of significant procedures on the bill and the hospital chart, and increasingly just kind of monitoring the patients and doing pain management through these unplanned low intensity, often sort of bill per diem admissions. However, this does not mean that we should go to our colleagues and tell them to just stop everyone at the gate. So there are no obvious remedies to this kind of cost, at least not through this exercise, because as we show in the paper, even when you look at patients with very poor prognosis at the time of admission, and even when you use data from within the first couple of days from the admission on things like blood test results, it's very hard to actually predict the exact timing of death. And many of them would survive the admission in even 2 months post-admissions. So it's difficult to even bound spending inefficiencies in the sense that it's not obvious at all that you would want to give up on these life weeks or life months that follow these eventually grim admissions. Finally, about age, we have this association that I mentioned that dissidents are higher spenders than survivors. And here we break it by age quintiles. We do more in the paper, but the general finding is that this difference, this elevated spending on decidencies, is a clear age gradient. So it's much starker for younger patients. Both overall spending is higher for younger patients and this difference between decedents and survivors. Now, admittedly, this could be due to different reasons. There could be indications and contraindications to treatment that are age-related, but we see it within all cancer types, and it's a very sort of ubiquitous finding. So we think it suggests, at least to some extent, that the decision-making, and this came up in the first presentation, the decision-making is not very localized. There's some long-term aspect in how decision-maker, be it the patient, the family, the doctor, or the system, think about the situation when they think about how intensive they should go. So to wrap up, the key findings are that elevated spending on decidency is mainly driven by higher inpatient spending. This is not mainly how cancer is treated, but this is the main explanatory factor in an accounting sense between decedents and survivors, particularly those low-intensity admissions, which increase as the prognosis deteriorate and are often unplanned and often at wards that basically just maintain the patients and monitor them. And this is a sort of consistent with this gradual dynamic shift that is different in timing by the status of each case, from curative care that is given to everyone in the beginning to more maintenance care that oftentimes is given in hospital setting. But nonetheless, it's sort of hard to say, at least sort of from this kind of analysis, where you would want to cut it, just because the base rate of dying out of these events is relatively low. So the positive predictive value would be low if you try to sort of train an algorithm and say who is going to die and try to cut spending on them. And finally, we have this clear age gradient that appears to suggest this kind of longer term horizon, as opposed to perhaps again the sort of straw man of just doctors just staving off near-term mortality mindlessly without thinking about sort of the broader implications. So this opens a lot of questions, maybe more questions than it closes, but we think that this is, even if it's not conclusive, because obviously nothing here is causal, we couldn't say what happened if we stop all treatment tomorrow or if we doubled all the intensity of care. But it is another indication that perhaps this idea that spending concentration is a problem is not so well founded. At the same time, again, we should caveat that this is not telling everything about care productivity per se, and I think it calls for more research of the kind we are as a profession doing into finding narrow settings where we could really put the spotlight and measure exactly and more precisely and more causally what is the additional marginal value of spending. Thank you.
All right, thank you, Dan. We'll turn it over to Maria Polyakova for a discussion of the paper for 10 minutes. And a reminder to everyone, keep those questions coming. And also, if you have questions about the other papers, feel free to put them in the Q&A now. We'll have a broader discussion later as well.
Thank you, John. Let me see if I can share my screen. Did that work? Okay, great. Thank you so much for inviting me to discuss this paper. It was a really interesting read. I must say, not the most uplifting paper. I was looking forward to, in the first days of the new year, hoping that the new year in general will have less news about mortality and kind of more positive news. So, but I guess this is very congruent with the spirit of 2020. So this paper by Dan and co-authors talks about end-of-life spending, and their main motivating fact is that a substantial share of healthcare spending goes to care for individuals in their last year of life. So this paper is going to try to tackle two questions, or really kind of one main question, but then there is a sort of underlying motivating policy question. The first one is, why is spending high at the end of life? And it's basically, it's kind of curious that, it is a very descriptive question. And yet when I was reading the paper, I realized that like before reading this paper, I had no idea where all of this spending at the end of life is coming from. And I think the anecdotal kind of picture that people would have is that these are extremely high intensity interventions in, you know, ICU units and so forth. And yet this paper is showing that this is probably not quite the case. So the focus of the analysis here is on trying to describe where the high spending is coming from at the end of life. And then the second question that the paper has, and I would say that it's more of an underlying policy question, they're not sort of trying to directly tackle it, is whether any of this spending is implicitly wasteful. And sort of ideally, we would want to, of course, quantify it. But as Dan described, the paper kind of informs this discussion and potentially opens more questions towards it, but is not going to try to answer this question directly. So they're going to zoom in into a particular population, and these are cancer patients, and they have fantastic longitudinal electronic medical records data, as well as claims data from Clalit, which, as Dan described, is the largest Israeli health plan. They observe lots of details of individual healthcare utilization before and after the diagnosis, which allows them to use a sort of careful machine learning methods to construct risk scores of predicted mortality based on a bunch of observables about these patients and before and after their diagnosis. And I would say the paper has 3 empirical findings as I kind of thought about it when reading it. One is that conditional on the same predicted risk of dying in year T, the amount of spending ends up being much higher on those patients who actually die in year T as opposed to those that don't. And as Dan described, there is kind of this discussion of ex post fallacy, which they can rule out in their empirical analysis. Second is that they're going to find that a lot of high spending at the end of life is driven by sort of maintenance rather than curative inpatient admissions. So this is essentially, as far as I understand it, is, you know, people are probably in pain or they have some kind of acute episode of while they are being sort of treated at home, and then they would come into the ED, be admitted to the hospital, and then the hospital kind of doesn't really do anything but probably ameliorate the pain, you know, stabilize the patient and send them back home. So they're not trying to somehow, you know, do any real treatment interventions. So that's what they call a low intensity admission. And that is going to account for a high share of the spending. And then a third very interesting fact is that the spending in the last year of life is particularly elevated for younger patients, which you know, they interpret as saying that basically the interventions are decided based on potentially life expectancy of the patient. So I really thought that this was unique and very interesting paper to read, you know, subject to the kind of grimness of the topic. It has novel empirical facts, is very carefully done, and it is really a super nice paper to read. And if you're interested in this topic, I highly recommend it. My main comments are really aimed more towards probably the next paper that you guys may or may not be planning on writing, rather than on how to improve the analysis in this paper, because I thought it was very carefully done. And I thought there are kind of 2 things that you can think of as the next steps. One is, you know, are there additional implications of the findings that can kind of shed even more light on other aspects of medicine that we usually kind of think about in the economics literature, as well as I think the second point, and I think that also just came up in the Q&A, is sort of, you know, what are the policy implications and how do we start thinking about these facts normatively, which I think is both very crucial and really hard, because it is not entirely obvious, at least to me, what is the, you know, the policy making objective function here and who is deciding what in this context. So the first point on interpretation of the finding, I think the key finding of the paper is that the timing of death is basically hard to predict, even with incredibly rich data. So the way the authors interpret this finding in the paper is basically to say, look, like this means that it's probably hard for us to say which, if any, of this care is wasteful. And so, you know, the fact that death is so unpredictable makes this argument about, you know, end of life care being wasteful much, much harder to sell. So I agree with that interpretation, but I'm also wondering whether there are other implications. Basically, what this is saying is, you know, unless we think the world and the way death works is really essentially a random draw, what this basically says is that medicine doesn't really understand what exactly triggers death at some very fundamental level. And as a consequence of that, we're not really measuring the right predictors. So that's kind of like a big picture takeaway for me. And I guess that's more relevant for potentially clinical research than for economics research. But I think what this also implies is that potentially, I think anecdotally, and this goes back to the discussion of the paper that Jason presented at the beginning, this idea of sort of cookbook medicine versus discretion. I think end-of-life spending, to me, anecdotally, it seems like that's an area where physicians would argue that, intuition is important, and it's sort of, you as a physician can have a very intuitive sense of, well, this patient is likely going to die faster than this other patient, even though it's kind of hard to write that into the chart. Like, it's not clear what do you write, but it's sort of this tacit sense that, this patient is in worse shape than this other patient, and that might trigger you to give sort of the same patients that look the same based on observables, different treatments. So to some extent, basically, I guess what I'm wondering is whether using your data, you have any hope of trying to understand the variance in the care that you observe provided by physicians conditional on the risk score that you compute. So you're clearly observing that people who end up, conditional on the same risk score, people who end up dying, they both have higher spending, but that also means that they just get different care. And is that somehow, like, can we unpack what is driving that? Do physicians actually have some kind of sense of who is more likely to die, even though you cannot capture that in the machine learning exercise? And what do we learn from that? Is this an area where discretion sort of turns out to be more important than in other settings? So that's kind of one aspect that I would have loved to see you think more about. And the second one is on normative issues. So, and I think that's much harder. So there were sort of several aspects to this that came to mind while I was reading the paper. One is in sort of to talk about waste, we kind of need to define the policymaker's objective function. And the paper kind of does it, but it does it in this very reduced form way, as I would think about it, in the sense that, we're just thinking about the return in mortality per dollar spending, and that's obviously totally fine. But what I'm curious about is what is the underlying, what is the underlying utility function essentially that drives this this return? So who is making the decision and who is getting what type of utility from these various decisions? Is it the physicians, the patients, the relatives? And I think that matters a lot in how you in how we might want to think about this, because it could be that also mortality gained per dollar spent is kind of not the right summary statistic measure, right? Because if people have, for example, some huge psychological effect for physicians from doing something, as opposed to just saying, yes, we know you're going to die in a month, we're not going to do anything, like that might be a huge cost. Similarly, for relatives and patients, you kind of have this, some aspect of utility from extra time or utility from hope, and those are not necessarily going to be captured by mortality outcomes per se. So sort of trying to understand what are the trade-offs here of each decision maker, and what is the policymaker's objective function? Like, is mortality per dollar spent sort of the ultimate summary statistic, or is there some way for us to dig deeper and capture these other objects? Would be very interesting. And then the other aspect of this is kind of, when we're thinking about wasteful, it's wasteful relative to what other benchmark. That wasn't obvious to me always throughout the paper. Are you kind of thinking about, not doing end-of-life care? Or, for example, are you comparing more intensive hospital care versus, for instance, you could imagine hospice care, which is kind of, you ex ante decide that you're only going to do the quote unquote maintenance care and pain relief, rather than trying to go back and forth with people going to the ED in and out for sort of more discrete interventions. So I don't know whether it's possible to think about this in a more systematic way, whether your guys are planning to do that. But I think that would be very interesting and important to just try to understand what is the policymaker's objective here, and what is even the social welfare function. And then one aspect I thought that is very closely related to that is this result about younger patients and whether that gives you some important insights about the normative implications of the paper. So you interpret the result that the spending is particularly, the end of life spending is particularly pronounced for younger patients as being about higher life expectancy in case of survival. My sense is that this needs to be reconciled with some kind of anecdotal evidence that you know, this might not be about the value, the expected value of care because someone is going to live longer if you cure them, but also about the value of extra 1 month of life may be substantially higher for patients and relatives who are younger. So you read all of these types of anecdotes about, you know, you have younger patients are much more willing to undergo much more severe or interventions because they want to spend, you know, an extra month with their children, not because they actually expect that they're more likely to be cured. And so that would be both consistent with kind of more aggressive treatment as well as more maintenance treatment. So it's not because you're expecting that this person will live longer, but because the current extra day is just much more valuable for younger patients than for older patients. And so the question is, you know, is there some way to use these differences in treatment choices between young and older patients to estimate kind of age curvature in the value of life? And can that inform the normative function that is kind of underlying the decision-making, both the actual decision-making that happens, that underlies your data generating process, as well as sort of what should this social welfare function be? Anyway, so this is a super interesting topic. I commend you guys on you know, taking it on and thinking about these hard questions, and I'm hoping to see more come out of this research agenda. Thank you.
All right.
Thank you.
Maria, and let me, we got 2 questions that I think related to some of the discussion. And then Dan, I'll say them and you can also just respond to Maria's comments. But they're basically 2 questions around what are the policy implications here? You know, and so I think that's an open question. It seems, you know, basically saying, well, these are consistent with more effective, you know, use of that information. What do we think about with respect to actual concrete policy? And then a follow-on is, well, is cancer in fact the best laboratory here insofar as we think it can be a more effective treatment, I guess. And so, you know, arguing that basically inefficient spending is stuff that doesn't work and doesn't prolong life. So those are 2 questions for you to answer, and then also can respond to Maria, and then we can open it up to broader questions of anyone in the group.
So thank you all for the question. Thank you very much, Maria, for this insightful discussion. So first of all, I should say that about prediction, we played with it in a separate paper. The fact that we observe EMR, we were curious about the ability to push further predictability, and it does help a bit, but it's not a game changer in the sense that a lot is already sort of absorbed in the very rich set of codes that we have to capture a patient situation. So and I mean, we are able to predict fairly well, but there's still a residual variation that doesn't allow to provide these kind of bounds. But it doesn't mean it's a bad prediction or anywhere near random. So there's this surprise measure of mortality. So this test where you ask doctors, would you be surprised if this patient would, you know, not survive the year? And we fare, for example, much better than this. And we fare much better than many other previous attempts because the data are very rich and the context is sort of geared towards us succeeding in predicting mortality. But still, I mean, the point is that there remains a lot of uncertainty. So I think in terms of, you know, one aspect of it, and, you know, we had this discussion with Salomon, who's an oncologist, I think there is an interesting future in incorporating this information from predictions with physicians' clinical practice. But the kind of big, I think, hazard is anyone thinking that this might sort of substitute for decision making, because there is still too much unknowns, too much noise, even in terms of like relatively short-term timing of very critically ill, very bad prognosis patients. So I think this suggests that we can predict fairly well, and this is interesting. But there's no immediate policy to be sort of driven out right out of this kind of factory of this predictor. I think in terms of other policy implications, and I think Maria was highlighting attention. We had writing this paper. We would love to talk about waste, and actually it was kind of the get-go motivation. Like, let's find like all these fats. And I mean, Israel is spending less than 10% of GDP on healthcare. So I mean, it's not, and still we see this huge end-of-life spike in spending. So maybe it's not so much about waste, but we really can't tell, and we didn't frame the paper in this language because it's just very hard to tell what is waste without the right source of variation. So that's not what we're doing. But I think the fact that there's so much hospitals involved does suggest, I mean, and then I would embrace Maria's framing as for the next paper. So I don't think we can say in this paper, but I think an interesting question for the future is whether, the opportunity cost of all these beds is such that, improving palliative care enough so that a lot of this maintenance care is done outside of hospitals could make sense. I know, speaking to to people at the Treasury, they're very worried about moral hazard, but we know there are ways to deal with that because when you take stuff out of hospitals, it's kind of hard to do the accounting of what and hard to monitor. But I think over the long term, and if you read Atul Gawande and others, I mean, it seems like palliative care is still underdeveloped relative to what it might be for these critically ill patients. Very good comments about family and understanding who is the decision maker. Again, I think this opens more questions than it answers, in the sense that it's really very, very hard to know. I should just say that Israel is not a fee-for-service system, so we can rule out sort of this more sinister aspects of this. This is not about doctors trying to make money. These are salaried physicians, and still we see this. And again, it's very flexible. We have ultra-Orthodox that would probably survive as fight for life even further. We have heterogeneity in preferences in the population, and there's a lot of flexibility. You can still give do not resuscitate orders, so it's kind of very pluralist in terms of what it accommodates, and still we see this kind of variation. So I would leave these open. I don't think we can sort of give definitive answers, but we think this makes for a very interesting sort of area of research. And about cancer, I think this can in principle be replicated in other conditions. Again, as long as you have this ability to predict and you have clearly defined events, then I think it makes for a promising sort of research agenda to try to compare different conditions and understand how things look at other places. Thanks.
Excellent. Well, I noticed that Ziad has politely raised his electronic hand. Did you have a question or comment for the group?
Oh yeah, I just wanted to say, Dan, this paper is so wonderful, and it goes into a lot, just as a much more granular and thoughtful paper than the one we wrote on the same topic. So thank you for that. And I read this, I really like that graph, the kind of like showing how essentially it does look like physicians are trying to turn the boat around on spending as prognosis goes up. So it looks like, in somehow like spending is responding to prognosis, and the worse the prognosis, the lower the slope of spending. So I think for me, I read that as, really in line with your last comment about looking elsewhere, for where the spending is coming from, and looking outside the hospital to patients and families and things like that. So I wondered if you'd thought about maybe, given that doctors are probably aware on some level of the mortality risk and trying to rein it in. What are the, what's the psychology? What is the family environment? Can you use any variation in whether people are living with a family member, distance from the medical center, things like that, to get some insight into, if it's not coming from the doctors in this non-fee-for-service place where they seem to be responding already, where is it coming from?
Yeah, this is a terrific point. I think when it comes to distance, in a separate project, we saw that, very sick patients are quite irresponsive to distance. So I wouldn't suspect that to be, it's a relatively small country, so we're not talking about hundreds of miles anyway. but I'm not sure. I think it's an interesting suggestion to look at the family and see, at least variation in terms of having kids or not, for example, for old cancer patients. I'm not sure, but this is a good place to look.
The questions from the panel or the audience? Did have one question just quickly around, you sort of bring up, and Maria brought up palliative care, and I think one, consistent with the earlier work too, that basically this stuff is so inherently hard to predict, even when you throw the kitchen sink at it. That's, in some sense, that's the nature of disease progression, seems to be the underlying theme here, that's, that we are not yet at a point where we can manage all of that. And so the question, I think, would be, are there models either in Israel or outside which are not as, I'll call it, discrete? I mean, I think one of the challenges with palliative care is that it's so discrete. It's essentially saying I'm moving to a different approach. Whereas what it seems like you're saying is that particularly for some people with a relatively bad prognosis, there's going to be lots and lots of complications. Are there more holistic ways to manage those complications that, and this is well outside the scope of the paper, but you've seen either?
I think, Being Mortal, the book by Gawanda, I think made me think that, and combined with our evidence that palliative care, I think we too much think about it as a kind of discrete absorbing state where you kind of move towards it only kind of at the very end, where it seems really to, I think, corroborate his approach and the others' approach that he sort of touts, that is something you should start at the day of initial diagnosis, is sort of saying that at some point, gradually things might go south, and then we want to kind of build infrastructure to accommodate that, which probably should also be tailored to the patient's situation. So not all patients are happy to be at home. Some really want to be at home. Not all patients, think about pain the same way. But treating it at the emergency department doesn't seem to be first best. Again, we can't show, but just my impression is that there might be improvements that have to do with the framing of this process as we now better understand it, given these data.
Oh, there's one last question. The question is that could be a way that cancer is treated in general? For example, start with high dose and bring it down, high cost to low cost for later stages. If you have a quick answer to that, I want to at least wrap it up because it will just boot us off unceremoniously if we don't do that.
I'm not sure I got a question, sorry.
Oh, it's sort of a question of, is there something inherent, you talked about this a little bit, is it inherently about cancer, about going through stages of trying different things, I think, where you start with a high dose and bring it down, or some learning in there?
Well, I know that Clay are doing some work about second-line diabetes treatment. I think in many chronic conditions, we have a sort of a sequential decision-making process, which is, by the way, another, I think, terrific area for future research. And, particularly in machine learning, how we kind of customize, sort of make this more precise and more tailored to the patient. I don't think this is particularly about cancer, but I'm not a physician. I would leave this open.
All right. Excellent. Well, I want to thank all of the tremendous presenters and discussants, and all of the audience members for sticking with us, whatever time zone you're in, and for attending this hopefully first and hopefully last virtual ASSA meeting. And everyone, enjoy the remainder of the meeting, stay safe and healthy, and thanks again to everyone. So I can clap, physically virtual clap. Thanks everyone for coming. If there are other questions, I guess we can stay on until it boots us out, but probably the opposite of that.
In about 1 minute.
Yeah, so anyway, any last minute things, or email the authors.
Thanks, John, for sharing this.
Yeah, thank you, John.
Thanks.
Didn't even have to use my
I think
laptop.
to
Easy.
Dan for suggesting it.
Yes, Dan is the brains behind the operation.
Thank you all for joining.
See y'all.
Bye.